Hi everyone, welcome back to another episode of Beyond the Script. Today we have Dr. Lesley Hawkins. She is an obstetrician and gynecologist at Humber River Hospital with special interests in medical education, contraception care, and robotic surgery. She is a founding member of the Humber River Hospital Rapid Access LARC Clinic, and she holds faculty positions at the University of Toronto and Queen's University. And she's here with us today. Thank you for being here, Dr. Hawkins.
My pleasure. Thanks for having me.
What do you feel like are some women's health issues that still, unfortunately, aren't taken seriously enough?
Good question. Women's health as a whole is just not taken seriously enough and not talked about enough.
Right.
So even having this conversation is so valuable because there are a lot of women's health issues we just don't talk about.
Yeah.
Or we're not educated about because it wasn't part of our upbringing or our schooling to be educated about those things.
Yeah.
So the things that are underrepresented or not thought about enough are, one, I think of basic screening. So one example is HPV screening. Used to be called a pap test or pap screening.
Yeah.
Now we have changed in Ontario as of March 2025 to HPV screening. HPV stands for human papillomavirus. It's the virus that causes almost all cervical cancers.
Wow.
And so now the patient experience is the same as a pap test, but we're testing for something called HPV.
Yeah.
And even talking about that. So, what's the standard screening interval? Am I higher risk? How often do I need to be screened?
Yeah.
Asking your doctor about that is really, really important. So that's one piece. And I think the other parts of women's health that we don't address enough or talk about enough are the things that are hard to talk about.
Yeah.
And so, sexual health challenges, terrible periods, things that we may feel embarrassed or ashamed to bring up with our provider.
Yeah.
And I can tell you from the perspective of a gynecologist, we would just encourage you to speak with your provider about these things, to bring it up. There's nothing we haven't heard in the gynae office. Let me tell you, we talk about these things all day, every day.
Yeah.
And so if it's a difficult question, something you're worried about bringing up, please know that there's no judgment, and we want to be able to help people with those things. And I recognize it's very vulnerable and difficult, but those are the things where we can make an impact on your health. So we want to hear about it.
Yeah, I think it's really amazing, especially for, everyone, especially women, to feel comfortable talking about their health and, OBGYNs like you creating a safe space for women to go and talk about things that are really uncomfortable or maybe embarrassing or awkward, anything. Like you said, that's why one of the reasons I'm happy to have you on here to talk about that, just to get women more understanding of the fact that there's nothing to be ashamed of. And like you said, it's the stuff you talk about is probably the equivalent of saying the sky's blue. It's nothing, not a second thought. So
I like that. I'm going to use that one.
Yeah, but, that's just what I imagine. It's like another Tuesday. It's nothing crazy at all.
It is another Tuesday.
Yeah.
This is another Tuesday.
Yeah.
All morning I was in the office talking about all of these things.
Yeah.
Sexual health, terrible periods, painful periods, vulvar skin conditions, a whole bunch of things, contraception, all that stuff, and abnormal vaginal discharge, for example. These are things that to me are routine for me to talk about, and so it doesn't bother me.
Yeah.
So I want patients to know that I recognize it may bother them to talk about it, and I think they're brave. Brave to come in. To come in is the first step.
Yes.
But so brave to talk about it.
Yeah, for sure.
I want them to know it's okay for me. We want to hear about it. We want to be able to help.
Do you feel like women are starting to get more comfortable with it, as in recent years, or do you feel like there's still a bit of that boundary, that barrier there?
I think so. I think we are talking about it more with each other.
Yeah.
And more with our daughters.
Yeah.
And I think that is helping because I think there are some gaps, generational gaps, where maybe our moms or grandmas didn't talk about it with us.
Yeah.
I think that plays into it. And I think there's also cultural influences on that and just how your family communicates and how you talk about those things.
Yeah.
So I think that's one piece. I think social media has helped a lot.
Yeah.
There are a lot of educators online who are helping to bring up these topics, which I think is so, so valuable.
Yeah.
And I think we are getting better. I think you're right, but I think we still have a long way to go.
For sure.
Yeah.
And you mentioned your daughters, or women's daughters. You have your own daughter, so I'd imagine you're probably planning to raise her in a way that makes her comfortable, just to even talk about the stuff with her dad, even. Like, so there's nothing off limits, and I think that's so important.
Yeah, nothing off limits, and she's 9, but one of the examples of educating her as she grows up is using the right anatomical terms, teaching her what a vulva is, for example, so that she can describe to us if she ever has, symptoms or a question about it.
Yeah.
So that's one of the basics for us at her age and stage, is just talking about the right anatomy terms.
Yeah.
And,
That's awesome. I think I feel like she's very lucky that she has you. Most kids don't have a parent who's so skilled and who's able to teach them things, and also teach them in a way for a 9-year-old to understand. Like, she'll grow up understanding things that a lot of women won't. So I think it's really cool that in your house, your kids will grow up understanding those things. That's awesome.
I hope so.
Yeah.
I hope so. But everybody else can do it too.
Of course, yes. And that's
definitely.
what your online presence has kind of done. You're kind of helping other people who don't have someone in the medical field to tell them everyday things. So yeah, that's awesome. What do you think what's something that women are told is normal but isn't?
Great question. I can think of so many things, particularly in gynae, but also in OB. So in gynae, probably the most common thing that people are told is normal is challenges with their periods. 2 main things: very painful periods and very heavy periods.
Yeah.
And often there is some genetic association with a family history of heavy or painful periods for one reason or another that's passed down, I find.
Yeah.
And that the older women in your family may say, well, this heavy period is normal. An example is what we call flooding. So being on your period and leaking onto your pants or your sheets at night.
Yeah.
We consider that abnormal. That's too much bleeding.
Yeah.
But in a family where everyone has very heavy periods like that, it could be normalized.
Yeah.
Or in anyone who has a heavy period and just thinks this is normal.
Yeah.
Maybe the friend that they confide in also has heavy periods like that.
Yeah.
And so it becomes normalized.
Of course, yeah.
And I think that sometimes healthcare professionals are also a culprit for that, where we could normalize something like a heavy period or a painful period and say that that's the usual thing when really it's not.
Yeah.
So educating ourselves about that is also really important as healthcare providers.
Yeah.
On the painful period side, definitely patients telling me that they can't go to work, they can't go to school because of how painful their period is.
Yeah.
To me, that's not normal.
No.
And that's something where we should work it up and offer some treatment to help.
Yeah.
So that those are 2 things, the heaviness
For
and the
sure.
pain.
Yeah.
On the obstetric side, one common myth that I can think of is that when you get close to your due date, so when you become close to the end of your pregnancy, a common myth that I can think of is that the baby will move less.
Okay.
And a baby moving less often is actually not normal. The frequency of the baby's movements should continue.
Yeah.
And I think a common myth is that they will decrease. And that might make a patient not choose to come into healthcare if their baby's moving less. Decreased fetal movement, we call it, or less movement, is a red flag for us and something that needs care and workup and making sure that everything is okay.
Yeah.
Because it could be a flag for a more serious problem.
Yeah.
And so it's a reason to come into hospital.
Speaking of misconceptions, I just would like to know just other things that you think people generally get wrong about pregnancy.
Oh, so many things.
You can take a minute to think about it or talk about however many you want.
I feel like every day with almost every patient, I'm talking about one of these things.
Yeah.
So let's see. There are lots of different categories, I guess, in pregnancy. So here's one category is exercise. So exercise is actually recommended in pregnancy as long as it's deemed safe by your OB or your family OB or your midwife, whoever your pregnancy provider is. Exercise in pregnancy is recommended.
Yeah.
Even if you were not exercising before.
Okay.
Or if in the first trimester, for example, you feel so sick that you can't exercise, it is recommended to exercise if you can as the pregnancy goes on. So that's one example.
Yeah.
I think the myth side of that, which is not true, is that you should only do activity that you were doing before.
Okay. Yeah.
And so, yes, like, don't become like an elite level cyclist in your pregnancy if you never did that before, but some amount of moving your body is recommended.
Just moving it in any way is ideal if you're able to.
With physical movement, as long as it's okay with your provider and you don't have any restrictions. Heavy lifting is safe in pregnancy.
Okay.
But that's often thought to be not safe.
Yeah, I didn't know that.
Which is a myth. Having sex is safe in pregnancy.
Yep.
Another category we could think about is diet. There are so many myths about diet in pregnancy.
Yes.
There are some myths that are about certain foods. Like one that I hear a lot is pineapple. Don't eat pineapple in pregnancy.
Oh, okay.
That's not true. You're welcome to eat
pineapple. Why that one?
There's a common thought that caffeine is not safe in pregnancy, but we do know that a small amount of caffeine, up to 200 milligrams per day, so about 2 cups of coffee, is safe in pregnancy and has no increased risk of adverse outcomes or complications.
Yeah.
That's one example.
Yeah,
so
absolutely.
Keep in mind that tea and some pops have caffeine in them as well. But about 2 servings of coffee is safe in pregnancy. One common one is dyeing your hair in pregnancy.
Oh.
That is safe to do.
People think it's not because of the chemicals, I guess. Is that why?
Yeah, but it is safe. So you can dye your hair and do your nails if you want to.
I was going to ask about like mental health as well. So like, I feel like we hear a lot about postpartum depression, but not as much as maybe prepartum depression, but maybe that's something that's more common than people might think. Would you say that's true?
Depression and anxiety during pregnancy is absolutely prevalent. Yeah. And it's important not to ignore those symptoms. So those could include symptoms of feeling sad, having trouble sleeping, having trouble concentrating, feeling like emotions are very labile or up and down, having anger outbursts, or feeling a lot of anxiety, feeling apprehension about doing certain things or leaving home, or having anxiety attacks, like a panic attack, for example. Those things can also happen in pregnancy. Yeah. And I think you're right. That is something that we don't talk about enough. Something to bring up with your OB provider if you're experiencing those things. Yeah. Another myth is that we can't treat depression and anxiety in pregnancy.
I was going to ask about that. Yeah.
And that's totally false. There are so many methods of treatment of mental health conditions in pregnancy which are safe. Okay. That's all the way from therapy to medication.
So there are some medications that are okay.
Absolutely.
That's really, I've read about women who, I can't imagine how some women I feel like are just unlucky and maybe have a harder pregnancy than others, or for whatever reason. I don't know the medicine behind that, but if they're having a hard pregnancy and they already struggle with depression or anxiety, and then they're kind of miserable for 9 months, of course their mental health is going to decline even more. And if they're not able to take their medication that helps with that, then it's just a really bad situation, I'm sure. So for women to know that, you talk to your doctor and there are solutions to it. You don't have to be miserable. You can do what you can to not be miserable for those 9 months, and medication is allowed in some cases.
Yeah, absolutely. Yeah, there are safe medications to treat those things and other mental health issues in pregnancy. And we know that pregnancy itself and childbirth is a huge event in somebody's life. Yeah. And so naturally it can be a trigger and a risk factor for a challenge with a mental health condition like that, even if a person has never experienced it before. Yes. And if a person has a history of something like depression or anxiety, then pregnancy and or childbirth will be a risk factor for that recurring. Yes. And so we know that in patients who have had a history of anxiety or depression, they have a higher chance, for example, of having a postpartum depression or anxiety. And so we try to prepare during pregnancy for childbirth and beyond, and making sure that they have the right supports, the right counseling and resources and medication if needed, so that they are well supported as they transition through birth.
Yeah.
Because that can be a big risk factor.
You were saying how obviously how huge, like big of a life change it is to give birth and have a baby. Since you see it pretty much like all the time, does the nuance of it go away, or are you able to kind of still think about the fact that like this is just another day at work for me, but this is like the biggest day of this couple's life? Yeah. Like, are you able to, I guess, think of it that way, or does it become so mundane to you? Or it could
definitely
maybe a little
not
both.
Mundane.
Yeah,
definitely not. I actually say out loud to my patients all the time on labor and delivery, I do this every day. Yeah. But I know that this is not every day for you.
That must make them feel better.
I think it helps. I think it helps reframe my mind as well.
Yeah.
To make sure that, we're not becoming in any way complacent about the huge impact that birth has on someone and on their family.
Yes.
And I think the day that we become complacent about that is the day we need to retire.
Yeah.
We should never feel that way.
Yeah.
We should always recognize what an impact it is on our patients.
Yeah.
And that's why most of us chose this specialty.
Yeah, absolutely.
So definitely not mundane, and definitely still very important.
You saying like, this is another day at work for me, so it's like no worries in terms of putting them at ease, I guess, but still making it known how much you still recognize the magnitude of what's happening. I'm sure that is really, I'm sure it's a fine balance, but I'm sure that's comforting.
Yeah, I think it is a balance. You're right. I think we want to communicate that we are capable of handling whatever emergency is going on.
Yes.
I think birth trauma is a huge area that we don't talk about enough either. And I can think of situations that happen in obstetrics where a major emergency is going on.
Yeah.
And it is so painful for us as providers to know that in some way this is a traumatic event for the patient.
Yeah.
And I can't fix that.
No.
Like, I can respond to the emergency. I can do my very best for the patient and for their baby, but I can't make that trauma that I know is there go away. Yeah. That part is really, really hard.
I bet. And probably, it's likely going to be long lasting for them. Like, I've heard women talk about their birth stories, and it's difficult to get through, especially when there are complications and emergency situations.
Yeah. I think that is something we should talk about more. Yeah. And talk about more with each other as well.
Yeah, definitely.
With other moms who have gone through birth.
Yeah. Yeah. What do you think is something that happens in the delivery room that would maybe surprise most people who have not given birth?
Good question.
Sure, it's another one that's probably a lot of answers.
Yes. Let's see. On the lighter side, at least in our Toronto hospitals, and I believe this would be province-wide. Yeah. When baby is born, they are registered under the birthing mother's name.
Oh, okay.
So the baby is identified by the last name, the surname of the birthing person.
Okay. I didn't know that.
And almost every time, let me tell you, that we put that name band onto the baby. Yeah. The partner or the family support person is like, wait a minute, that's not going to be their name. And it happens every day. Yeah. And I appreciate them advocating for that. Of course. But I'd like everybody to know that it is a standard of safety, safety practice, that at the first birth time, the baby is identified by their birthing parent. Okay. And that subsequently you can go ahead and register your baby in the provincial system under whatever name you would like. Yes. But while they're in the hospital, they are identified by their birthing parent's name. Wow. So my daughter had my last name for a few days. Okay. And then, as is traditional in my family, we named her surname after my husband. Yeah. But that is something that comes up all the time.
That is funny. It causes a moment of panic for
yes.
or maybe the partner or something.
Yes,
that's really funny.
Exactly. Yeah.
That's good. Is there something about childbirth that you think is pretty misunderstood?
Yeah, I think on a more serious note, which we've touched on already, is that I think a birth plan is a misnomer.
Yes. Okay.
I really care strongly about patients sharing with us what's important to them in their childbirth hopes.
Yeah.
But I think the term birth plan is just such a poor term.
Okay.
Because birth never goes to plan, to be honest. Rarely goes to plan, I should say. And there are always things that come up that none of us can predict. Yeah. Patient, provider, we just don't know what's going to happen in a birth. We don't know how a labor is going to go. We don't know how a surgery is going to go. Yeah. We don't know if there's going to be an emergency or a tweak in the plan. Yeah. We don't know how the patient's going to cope with the experience of their labor, for example. Yeah. They may cope with pain differently than they expect they would. Yeah. They may need to change their pain management plan. Yeah. We may need to change the plan for birth with their consent, depending on what's going on. Yeah. And so that's one thing that I wish we would stop using that term, birth plan. It doesn't mean I don't want to know about the patient's wishes. I really do. Yeah, for sure. I really do. That's so important for their experience. Yeah. But birth rarely goes to plan. Yeah. Yeah. And we see that every day. Yeah. And people, I think that most patients who are going through childbirth, most do not understand that part. Something could change to anyone. Yes. Even if you have no risk factors. Yeah. Something could change. Yeah. Something, unfortunately, could go wrong or could go better than we thought. Yeah. Things could just be different. Yeah. And I wish more people knew that. Yeah. And you can only do as much as you can. Yeah. And also the patient can only do as much as they can. Yeah. Yeah. And so I think there's a lot of guilt associated sometimes with a plan that doesn't go to plan. Okay. Yeah. Guilt on the birthing person. I've heard about that. Yeah. That feels terrible. And we should just throw that out the window. Like nobody needs to be guilty about anything. No, we're just all doing our best. Of course. I've heard of women saying like their plan is to do no epidural, no medication at all, and then they get into the situation and feel I've seen videos of women say that they feel weak for asking for an epidural or that they should be able to do it with no medication. That to me, so I'm silly. Like, it's so silly. That is brutal to me. Like you're either pushing a baby out of your body or getting it like surgically cut out of your abdomen. Like either of those situations are, I don't think anyone should be expected to do that with no medication. But I would love to know how do you navigate those situations when when a patient's wishes kind of conflict with what your medical advice is? Good question. Those are really challenging for us and for the patient. Ultimately, the number one pillar of approaching that is that a patient's autonomy is the most important. That's their ability to make decisions for themselves and for their own health care. The patient decides. Ultimately, that's the bottom line. The patient decides what's the best for them. Okay. And it's my job to give them the options and my recommendation. Okay. And that's all you can do. That's all that medicine is about. Yeah. Like we are an expert in our field, giving a person our opinion and our recommendation for what we think will be the safest. And ultimately, we would need a patient's consent to go ahead with any intervention. Yes. And so how to navigate that, it's a lot of discussion, a lot of talking about the pros and cons of the different options, alternative options. I think before even doing that, it's about understanding from the patient what their goals are and what they want and what they are hoping for. Yeah. And if I know, that's why I said it's so important to know somebody's birth preferences and hopes. Yeah. Because if I know where they're coming from and I know what their hopes are, then I can do my very best to achieve those. Yeah. Or to explain why I can't achieve those. Yes. It might just be helpful to explain why an assisted vaginal birth is not feasible in this situation and that a cesarian section is the recommended safest choice as an example. Yeah. If I know where they're coming from and what they were hoping for. Yeah. That can be really, really helpful. Yeah. What's something that makes a C-section safer as opposed to a vaginal delivery? There are many general reasons for C-section. Yeah. There are reasons in labor and reasons when someone is not even in labor yet that they might need a C-section.
Okay.
Generally, there's one category of the baby having fetal distress or we would call it like an abnormal fetal heart tracing.
Okay.
But basically the baby being in some distress.
Okay.
And that could be a reason for a C-section.
Okay.
Another reason could be in labor, that the labor's not going well. They're not dilating well.
Okay.
And then a C-section is recommended if we're unable to achieve labor where they're dilating all the way to being able to push baby out, for example. There are like certain safety criteria to when we would offer somebody an assisted vaginal birth versus a C-section.
Okay.
And sometimes we offer both options and we talk about the pros and cons with them.
Yeah.
But say a patient is in labor, they're not dilating anymore past, say, 5 centimeters of dilation. The cervix needs to be fully dilated, or 10 centimeters, in order to even have a baby be able to safely pass through the birth canal.
Okay.
So if you're only 5 centimeters and we're stuck in the labor's not going well, that's a situation where I could not offer a vaginal birth.
Okay.
And I would have to offer a C-section.
Yeah.
Does that make sense?
Yeah.
But there's many different categories. There's other general categories where someone might need a C-section.
Okay.
Say a baby's breech, which means feet first.
Yeah.
That could be a reason for a C-section in many circumstances. Say a patient has twins, there could be a reasoning for C-section.
Yeah.
Not all twins, but some twins in certain situations.
Yeah.
There could be a placenta problem, so a problem with the placenta that would block vaginal birth.
Wow.
That's called placenta previa.
Yeah.
There are maternal medical conditions, so medical conditions in the birthing person where we cannot safely go through labor.
Oh, wow.
One example could be if a patient has a heart condition where the stress of labor or the act of pushing during vaginal birth, for example, would not be safe. So that patient might need to have a C-section.
Yeah. Is it because like their heart rate it might be too stressed?
Yeah, their heart for different reasons maybe cannot tolerate the stress of going through labor or the act of that Valsalva maneuver where you push.
Okay. Oh, yeah. Okay.
And that could be dangerous to the person's heart health, as an example.
Yeah.
And so there are so many reasons, potential reasons, why, for safety reasons, like one intervention could be safer than another.
Yeah. Are there moments, and if there are you able to share a time like where you've had to make a split-second decision kind of in the moment of someone giving birth or during their labor that has maybe changed the outcome, or what you've realized, oh, this is not the best option, we're going to have to make this decision very quickly, and how do you deal with that pressure?
Yeah, good question. We are trained for many years to deal with those situations.
True, yeah.
Obstetrics changes lightning fast. Yeah. Emergencies can happen in seconds.
That's so scary.
It is a high acuity specialty.
Yeah.
So things could just all of a sudden turn the corner.
Yeah.
Something could change.
Yeah.
And our whole team is trained to react to those things. Some examples could be something like a cord prolapse, which I had the other day, where patient was in labor and the umbilical cord fell down in front of the baby's head. This then blocks off the blood supply to the baby, and the baby is in acute distress. The baby has to come out right away in order to save the baby's life.
Wow.
And so in that situation, we call in our hospital what's called a code OB, where that's called overhead in the hospital, and the whole team comes to help.
Yeah.
And we have to, with the patient's consent, do an emergency cesarian section and get baby out as fast as possible. Yeah. And so usually in the order of just a few minutes, baby is already out and delivered. And that is one example of a real big emergency in obstetrics.
Because that could lead to a worst case scenario if it's not treated.
Yeah, because the baby's brain will not receive enough oxygen after a certain amount of time because their blood supply is being cut off because their umbilical cord is coming in front of their head, as in like down and out. Yeah. And so it's being blocked off by the pressure of their head and the pelvis.
Yeah. I have 2 questions. Can that just happen at any point? Just the cord can just, I don't know, you said like it falls and just happens? It can
really happen at any time.
And there's nothing that anyone can really do to avoid that. You just have to treat it if it happens.
Yes, there are some risk factors for it happening. Yeah. But in this example that I'm thinking of from the other week, there was no risk factors. It just happened. Yeah.
So I guess in the example from the other day that you're talking about, I assume you have to pretty quickly explain that to the patient, like this is what's happening, without trying to make the patient panic too much. Because of course, if you're giving birth to your baby, that's probably a terrifying thing to hear. But is there a way that you go about explaining that in a timely manner while also trying to reassure the patient that you're going to do everything you can to make sure the baby's okay and the mom is okay?
Yeah, this is one of those situations I was talking about earlier where trauma feels unavoidable.
Yeah.
And that's really painful as a provider.
Yeah.
But in that situation, like in a cord prolapse, we have to, first of all, keep our hand in the examining position, which means my hand is inside the vagina. I'm pushing the baby up to relieve pressure on the umbilical cord.
Okay.
I am actually hopping up onto the patient's bed. So I'm sitting on their bed. And then their hospital bed is being wheeled to the operating room.
It's being wheeled in. Wow.
Yeah. So this is traumatic on so many levels, and it's so difficult. But basically, I just have to use the time that I have on the way to the operating room to tell the patient, this is a big emergency. I can't take my hand out.
Okay.
Your baby's life is at risk.
Yeah.
I recommend we do a cesarian section as soon as possible to preserve the health of your baby.
Yeah.
Is that okay with you?
Yeah.
And that's kind of the way we phrase it. And if we can just quickly summarize what's going on and explain this is a big emergency.
Yeah.
That's what I tend to say.
Yeah.
And they can also, a patient can usually tell because 20 people are running to our aid, right?
Yeah.
The whole team is coming.
Yeah.
And the code is being announced overhead.
Yeah.
And so they can tell something really serious is going on.
Yeah.
And it's my job on the way to the operating room to explain what's going on.
Yes.
And to just say, we're going to do our best to keep you and your baby as safe as possible.
Yeah.
Is it okay if we go ahead with a cesarean section? This is the only safe option in this scenario.
Okay.
And we try to have that conversation on the way to the OR, but we usually only have 1 minute or maybe 2 minutes. And then
that is not a lot of time.
The patient is often going under a general anesthetic for this scenario.
Oh, yeah.
And we're getting baby out as soon as we can.
Generally, like I would assume if a patient is hearing something from a doctor saying this is what I recommend, then that they're on board with that. But do you have there been patients before where they've said, I don't want a cesarean. I'm really committed to pushing. And have you had to navigate that as well in a really quick moment?
Yeah, we have. Yeah. And all of us OBs have certainly been in that situation.
That must be hard.
It's really hard.
Yeah.
As I touched on before, the core pillar is the patient's consent.
Yeah.
Right? So
of course.
if they say no, then we will never perform a surgery on them.
Yeah.
That is their decision.
That's their boundary, yeah.
So then it's about exploring why and trying to explain how serious and time sensitive the situation is.
Yeah.
And that unfortunately, in this situation, for example, I don't have a safe alternative.
Right.
The alternative of saying no is the patient's choice.
Yes.
But in my view, it's not a safe alternative because we could lose the baby.
Yeah.
And so having that conversation is really difficult.
I bet. Yeah.
It is rare that somebody would decline, but it certainly has happened.
Yeah.
And we come back to that. Okay, is the patient understanding what we're trying to explain? Because it's hard to explain in such a short amount of time.
Yeah, of course.
What are the patient's views? What is it about responding to this emergency that they're not okay with?
Okay.
And how can we help make it better?
I assume getting the baby out safely and to the parents or parent, I assume that makes all of this worth it. Is there something that's the most rewarding part of your job if it's not that, or is it just helping people grow their family, or there's something in general?
Yeah, I think in those situations, part of the reward is the outcome, the safe outcome.
Yeah.
But the other part is all the other bits. The safe outcome only takes us a few minutes.
Yeah.
It's all the other care of the patient. like meeting with them when they're awake after their surgery and debriefing what happened and telling them what happened. It's all the other pieces of their care that are much more important in my eyes. I think the outcome of a safe delivery is a relief feeling for us. Like, oh, baby's okay. But that is fleeting. I think the weight of all of the other parts of the care are so important to us. So like meeting them multiple times afterwards so that they can ask all of their questions, debrief about what happened. They may have been like under general anesthetic for that and may not be aware of what's going on. And explaining what happened and why is something that is an ongoing conversation afterwards. And so we often do that multiple times.
When you're helping deliver a baby, whether it's vaginal or cesarean, after the baby's out, are you able to kind of take in the moment and, you know, are you able to see these parents really experience this for the first time, or are you usually pretty focused on like, I need to sew this up right now, I need to, you know, clean everything up? Like, are you able to be in that moment, or is it?
Sometimes I still get teary-eyed.
Oh, yeah?
For sure, Yes.
I was going to ask about that, if there's, like, emotions that come with it.
I think if baby and mom are healthy, everything's okay. Then I take a minute to just take in the moment. And for me, that minute is during delayed cord clamping. So after the baby's born, if baby and mom are healthy, the guidelines recommend some delay in clamping the cord. And so we don't have to clamp or cut the umbilical cord right away.
Oh, I didn't know that. I didn't know there was some time.
There's some time. It's not a rush. In a healthy mom, healthy baby situation. Usually we're waiting somewhere around 1 to 2 minutes to cut the cord. Also depending on the patient's preferences, but that's our medical recommendation. So there is this moment where baby is usually on mom's chest and everyone's just soaking it in and taking it in and everyone's, you know, the family's crying or the support person is crying or whoever else is involved. And the patient's primary nurse, who has been with them for their whole labor usually, is checking out the baby, drying them off on mom's chest and making sure they're okay. And, you know, baby's screaming and everybody's really happy. And for me, I don't have to do anything in that moment. I get a break. And so I usually just like take a step back and I just get to soak it in. That is the best time for me.
I bet.
And then after a minute or so, I get to go back to work and clamp and cut the cord and move on. But if it's a healthy delivery, then that's my minute to take it in. And in some situations, definitely tears still come to my eyes, even after many, many years.
See, I love that. I think that's who, if I was giving birth, I would want someone who cares so deeply. Like I think it's really special that you say that you, after, I mean, I'm sure you've delivered so many babies, but you still have those moments where you realize like this person was not in the world before, and now they're here, and these parents or parent is able to experience this. Like, I think it's really nice that you have that kind of empathetic and compassionate part of it that's hasn't gone away yet in all the years of practicing medicine. And also, I feel like obstetrics is a specialty where that is able to happen. Like, I'm sure cardiologists, there's probably a lot like cries of relief if someone makes it through a very intense surgery or something, but I would imagine it's not quite the same as seeing someone come into the world for the very first time. That's a pretty amazing feeling, I bet.
I don't know. I can't comment on my
Fair
colleagues.
enough, and neither can I.
They chose their specialty for good reason.
Of course.
For sure. So there must be some equivalent there. But for me, of course, I'm biased as an OBGYN. There's nothing better than a delivery. Particularly one that goes well.
For sure.
But there's nothing better than that, for sure. And there's something special as well about being the OBGYN is that once the baby is born, the baby is not my patient anymore. The baby is the patient of the pediatrician. And so I get this special role as an OB, as do all my colleagues, where our job is to focus on mom. And when baby's born, it's easy for lots of other people in the room to focus on the baby. That might be the family, support people, of course, everybody's focused on the baby, right?
Yeah.
But it is my sole job is to
Yep.
focus on mom.
Yep.
And in my hospital setup, my teammate, my primary nurse, the nurse who is the primary nurse to the patient, their primary job most of the time is also to focus on mom, because another nursing colleague gets to focus on baby.
Yes.
So there's two of us in my delivery scenario, and this isn't the case at every hospital, but in our setup, there's two of us where we focus on mom only.
Okay.
And we take that really to heart.
I bet.
Because it is very easy for all of the hullabaloo to be around the baby.
Of course.
And it's our job to really support mom.
Yes.
And focus on her and make sure she's okay and she's safe.
Yeah.
And so that's an important part of our job too.
Yeah, that's huge. And it's great that you guys are focusing on the mom, because I feel like it's possible the mom maybe not even focusing on herself, maybe being focused, she's focusing on her new baby.
Yes,
and so it's good someone's watching out for the mom. I mean, that's having just delivered a baby, someone needs to obviously take care of a lot of things there.
That's true. Yeah.
Yeah. How do you feel like you can support patients who are going through a really difficult pregnancy or childbirth, knowing that there is only so much you can do?
Yeah, good question.
You can take a second. I'm sure that's probably a heavy hitter one, but
yeah. I think for me, I think about what I can do, but I also think about what the whole team can do.
Yeah.
Making sure that they have great nursing support, great counseling support through our social workers, for example.
Yeah.
Great resources, whatever we can help them with.
Yeah.
Support through other members of our team, like with things like pain management or with lactation from our lactation consultants.
Yeah.
I never forget that this is a multidisciplinary team that's there to support them. So that's really important.
Yeah.
I think for me, supporting the patient, I draw on a few things. I draw on all of the experience as an OBGYN, all of those mountains and all those valleys that we experience reinforce what a miracle birth is and just having a baby is. And for me, I also draw on my personal experience of going through pregnancy loss, ectopic pregnancy, going through surgery when I was postpartum myself.
Wow.
Having an obstetrical complication that was really formative, I think, for myself in me being able to relate to my patients.
I bet that's huge.
And hopefully help them a little bit better than I could before I had
bet.
a baby.
Yeah, for sure.
And I certainly don't think that's necessary to be a stellar obstetrician at all. But it is human to draw on your own experiences. And so I always think of those things about how I felt when I went through pregnancy loss, when I'm helping a patient through their loss. And I think that can be helpful.
Yeah, absolutely.
It can be helpful to know how to support them a little bit better.
For sure. And I feel like even just them knowing that you have, like you said, you don't have to have had the experience, but knowing that their OB has had the experience, I feel like even that would be helpful just for the emotional support, or just to know, like, I'm not only am I not the only one who's gone through this, but my medical caretaker has been through it herself as well. I would imagine that would be a really, really helpful thing for them. Yeah,
and I think in medicine we don't always share our own personal experience with our patient because it may not be useful. Yeah. But there are some moments where sharing our own personal experience could be helpful for the patient. I can think of this situation where I was on call and a patient needed a surgery for a miscarriage.
Okay, wow.
And I was holding their hand before they went to sleep in the operating room. Wow. And they were really scared, really, really scared. Yeah. And they were about to undergo something called a D&C, which is to treat miscarriage, which is basically a surgery to remove any remaining pregnancy tissue if there's some stuck inside after a miscarriage. Yeah. And she was scared, and I told her, like I always do, we're here for you. We've got your back. Yeah. And I said to her, we're going to do our best to keep you safe. And I know this because I was in your position before.
Yeah.
And actually, I had the same anesthesiologist that was about to put her to sleep.
Oh, my God.
Who put me to sleep for my miscarriage.
Oh, my God.
And I said, it's going to be okay.
Yeah.
I've been here, and my colleague kept me safe, put me to sleep, and took care of me.
Yeah.
And we will do the same for you. And then, my colleague, the anesthesiologist, said?
What?
She said, yeah, I'm part of this club too, and it's a bad club. And it was really sweet.
Yeah.
I'm just getting emotional thinking about it.
Yeah.
But the three of us were all part of this terrible club that nobody
Yeah.
wants to be a part of.
No.
But another thing that we don't talk about enough.
Yeah.
So it was nice it was healing.
Absolutely.
To feel not alone.
Yeah.
And I think there's a balance in that, because you never want to take away from the patient's experience. Like,
Sure.
I never want them to think that I'm talking about myself.
Sure.
So there is a balance in that.
Yes.
But I wanted her to know that, I've been there before, and that everything was okay.
Yep.
And that we can only promise to do our very best. And
Yeah.
I know that my colleague will do that for her. So I think that's a time when we can share a little bit and use our own experience to help care for people.
Yes. Thank you for sharing that. I know that I can only imagine that was how vulnerable, and it's probably really difficult to still talk about, but I appreciate you sharing that for anyone listening who maybe has had that experience or will have that experience.
Yeah.
Like you said, it's a club no one wants to be a part of.
Yeah,
But
it can be very lonely.
Yeah.
Yeah.
But it's a club that I think it sounds more common than maybe people think, right? Yeah. So
it's so common.
Thank you for sharing that.
Yeah, no problem.
Yeah.
It can be so lonely because we don't talk about it enough.
Yeah.
But it is so common.
Yeah. And I would just again, feeling like if I knew my doctor had been through this, to me, everyone's different. To me, that would, I think, provide a lot of support for me. So what is one piece of advice you would want everyone to know before getting pregnant, or maybe newly pregnant people?
That's a good question. One piece of advice I give everyone is to talk with their provider, whoever that is, their midwife, their family medicine obstetrician, or their OBGYN, to talk with them about what their risk factors are in the pregnancy.
Yeah.
So just asking, am I having a low-risk pregnancy? Or asking, hey, are there any complications in my pregnancy that I need to know about?
Yeah.
Sometimes things come up, and I want to make sure that the patient knows and is equipped about what to expect if they have a risk factor. Like one example would be, say, a patient comes to have gestational diabetes during their pregnancy. So diabetes of pregnancy.
Okay.
It's important that they understand the possible impacts of that on their pregnancy and on their delivery.
Okay.
And so my advice would be to keep up to date with your provider about any risk factors that you have that could put your pregnancy at higher risk.
Okay.
Yeah.
If everything is otherwise healthy, but a person is having multiples, does that make it a high risk pregnancy? Because they're more...
It makes it higher risk for sure.
Okay.
Yeah. We don't tend to use a hard label of high risk.
Okay.
Or not high risk.
Yeah.
That is a bit of a myth as well.
Yeah.
People will ask me, okay, am I labeled as high risk?
Okay.
And I would say, well, everyone's so unique, right?
Yeah.
Everyone has a different set of risk factors.
Yeah.
Everyone's pregnancy could be not complicated or complicated in different ways.
Yeah.
So that high risk label is a bit of a misnomer
Yeah.
to just blanket say that you're high risk.
Yeah.
But you're right. Multiples, which refers to anything more than one baby in the uterus, is considered higher risk pregnancy, yes. And that increases with the number of multiples that there are. So what we call the order of multiples. So triplets would be higher risk than twins, and quadruplets would be higher risk than triplets.
Have you ever dealt with triplets or quadruplets before?
Good question. Only in residency did I deliver triplets.
Oh my goodness.
But in my current practice at the hospital that I'm at, we do not have the higher risk in the triplet order. So at my hospital, we only go to twins.
Okay.
But all over Ontario, there are various hospitals which we call They usually have a level 3 NICU, which is the highest level of NICU, which is the neonatal intensive care unit. And they are more equipped to take care of early babies because higher order multiples have a higher chance of being delivered earlier.
Yeah.
And also their department of OBGYN will have maternal fetal medicine specialists, which are OBGYNs like me, but they've done extra training in a subspecialty called maternal fetal medicine, which means extra years of fellowship where they learn to take care of higher risk pregnancies, including those higher order multiples. So they are equipped to deal with triplets and quadruplets and another special type of twins called mono twins. So those higher risk multiples will be usually cared for at what we call a tertiary center, which is a center with MFM group and a level 3 NICU.
I didn't know mono twins are considered high risk. Is that because if not all twins, I guess, are considered high risk? It's interesting that category is. Is that when they're identical and they're in the same sac? Is that? That could be completely wrong. I have no idea.
Yes, you got it. Yeah, you got it. So there's 3 types of twins in general. Yeah. 3 types clinically that we know impact their outcomes and their risk level in pregnancy. Yeah. Those 3 types describe whether they share a placenta or have their own placenta, and whether they share a sac, a water bag, an amniotic sac, or whether they have their own amniotic sac. And so you're right, mono twins, they have, the mono refers to one, so they have one placenta and one sac. So they live in the same sac and they share the same placenta. And they are the highest risk type of those 3 types of twins. The other types in risk order are mono di twins, which stands for monochorionic diamniotic. That's 1 placenta, 2 sacs. And then there are di twins, which are the lowest risk. Di is dichorionic diamniotic, so 2 placentas, 2 sacs.
And if that's the case, the twins will definitely be fraternal, or not definitely.
No.
Oh, it could.
So fraternal and identical twins. Medical term for that is dizygotic and monozygotic. To be honest, in clinical medicine, we don't care about that very much. We care more about the physical type of how the twins formed. So we care about whether they share a placenta and they share a sac.
Got it.
We don't care so much about whether they're identical or fraternal.
Fair enough.
But the twins that we were just talking about, so the lowest risk twins, those di ones, separate placenta, separate sac, they could be identical or fraternal. It depends on how they formed.
That's interesting.
The ones that share a placenta, the ones that start with mono, those are all identical.
Okay, all of them. My 2 of my brothers are they're fraternal twins.
Cool.
And my parents told me recently, and if you look at them, they're very, very fraternal. They don't look anything like twins, but they are. But it was interesting because my parents told me that the first few days they did 2 different tests, and they said we're thinking they're fraternal, but we did one test that said they're identical, and one said they're fraternal. So and this was, like 30 years ago, but it's interesting I had no idea that it's interesting, like even when the babies come out, you still might not know. I guess that's really cool.
You may not know. One of the only guarantees to know is if you have female male twins, then you know they're fraternal.
I feel like I've heard, like you always hear, like over 35 is considered a higher risk pregnancy, I think, or a geriatric pregnancy. Is that still the stat, or is it now that I think women are having babies later? Is it more adaptable now to have? Is that better?
Women are definitely having babies older. And we don't use the term geriatric pregnancy anymore. Above age.
We'll check that out.
No, it's good to ask. It is a term that was used before. Absolutely. We don't use that term geriatric pregnancy anymore. But it is a term that was used before. Now we use a term or a phrase called advanced maternal age. AMA, we short form it too. And in general, we use AMA or advanced maternal age to describe a woman over 40.
So women over 40 usually.
It's not that the risk bar has moved necessarily. over age 35, there are still increased risks in pregnancy.
Okay. Yeah.
Particularly of genetic problems that could happen in a baby that go up after age 35.
Okay.
And other pregnancy complications go up as we get older.
Sure.
But these days we are focusing more on the modifiable risks at age 40 and above.
Okay.
And so we're using advanced maternal age as the phrase.
Yeah.
Got it. At age 40.
That's good to know. Yeah. I hope people hear that and use that in the vocabulary.
Yeah.
That's really good to know. I will ask my last question. If you can explain just maybe what the most, this is supposed to be more lighthearted, but what the most kind of unexpected or craziest thing that you've experienced, maybe giving birth or just during your medicine career, your medical career at all, if you can think of a story.
Yeah. One that comes to mind is on the lighthearted side.
Okay.
We had a patient when I was a resident who was having a labor and vaginal birth. Mm-hmm. And the whole family was there. Okay. Lots of people.
Yeah.
Okay, whole family is exaggerating, but many people were there in support, in a good way. Mm-hmm. And I walked into the delivery room, and the whole room was decked out in pink. There were pink balloons. There was a pink diaper bag. Okay. Everything was ready for the girl.
Oh, gosh.
And guess what was born? It was a male. And everybody was shocked. Like, patient was shocked. Family was shocked. Baby was healthy. That's all that mattered.
Of course.
And everyone was happy.
Yes.
But I just kept picturing for the rest of the weeks after that when I thought back about that experience of being surprised.
Oh my gosh, I bet.
Meeting who you were expecting to meet.
I bet that would be crazy.
Yeah. But that happens rarely, but once in a while, yeah.
Do you feel like people generally or at least the patients you see, do they generally like to know the sex of the baby before, or do you see a lot of surprise gender reveals?
Majority want to know.
Yeah. I guess that makes sense. Well, I guess you never know, but
you never know. Fetal sex determination is about 98% accurate.
Oh, okay.
On ultrasound now.
Okay.
So, and then it's even more accurate if you've had some genetic testing. Yeah. That would tell you the sex of the baby. Yeah. So it is quite accurate, but nevertheless, once in a while,
some people we
get a surprise.
Wow.
Yeah.
Wow. Yeah. Well, I think those are all my questions. Unless you have just some piece of advice that you'd want to give to all women just for their health, or if they're pregnant or giving birth, or just generally, if there's something you want to say.
No, I think it's just a great opportunity to talk about these subjects more.
Yes.
And I would encourage everyone to keep the dialogue open.
Yeah, absolutely.
We're only going to get better about reducing the stigma of talking about women's health and about educating ourselves and our communities if we talk about it. Yes. And so keeping the dialogue open and asking questions. Yeah. And looking for reliable sources is also a big thing that we have to be careful of because there are a lot of misinformation sources out there, particularly that are targeting vulnerable times in people's lives, which are very common in women's health. Yeah. And so we have to be really careful about that. But seeking reliable resources that are evidence-based and talking about it, whatever it is, can be really, really helpful. Yeah,
and I think that's what you're doing on your social media. I think it's so cool that you're doing that. I'm loving seeing doctors do that because it's it can be an educational tool for people in that way, and also just, if nothing else, getting people more comfortable talking about that. Yeah. So if you'd like to go and see what Dr. Hawkins is posting about, where can people find you?
They can find me on Instagram at Lesley Hawkins MD.
Okay, sounds great. I've looked at her profile many times, and I definitely recommend following it. Thank you so much for coming in today. This was a really interesting conversation.
Thanks for having me. I really appreciate the time.
Absolutely. Bye, everyone.